My name is Ashley Dunkerson, and this is our group teaching project for NU 469. Our project is on encephalopathy. The content that we're going to go through is the definition and description, incidents, risk factors, pathophysiology, common signs and symptoms, diagnosis and treatment, prognosis, ethical issues, impact on patient, family, and society, and nursing diagnosis, goals, and interventions for encephalopathy. Objectives is just some things that we want you to learn from this teaching project. We want y'all to be able to restate a broad definition of encephalopathy. We want you to be able to restate 3 causes of encephalopathy. Be able to list at least 5 signs and symptoms, be able to list 3 diagnostic tests for encephalopathy, and be able to restate 1 nursing diagnosis, 1 goal, and 1 intervention of encephalopathy. Definition of encephalopathy, what is encephalopathy? It's just a general term meaning disease, damage, or malfunction of the brain. It usually stems from an altered mental status change, usually accompanied by or may not be accompanied by physical changes. Encephalopathy is a very broad term, which is usually preceded by what causes the brain malfunction. It can be like in hepatic encephalopathy, it's liver damage, or it can be anoxic encephalopathy, where it's just not enough oxygen to the brain that can cause damage. Severity of the condition depends on the cause. Symptoms may range from mild alterations of mental status to severe and potentially fatal manifestations, such as dementia, seizures, and coma. You can see encephalopathy anywhere from a newborn all the way through adulthood. Just depends on what causes it. Damage may be reversible or in some cases permanent, depending on the cause. A little history on encephalopathy. It can be dated back to Europe in the 1840s. Children were suffering from what appeared like seizures, but they didn't really know what the cause or what exactly seizures was, but they were displaying mental deterioration and just erratic behavior. The origin was unknown, or the reason was unknown, and in the 1970s, this condition was finally labeled as encephalopathy. Incidence of encephalopathy, it just really depends on what causes it, but it's just difficult to determine the various causes of encephalopathy. An estimated 200,000 cases are reported in the U.S. each year. Ages commonly affected are 40 and older. Some causes in children of encephalopathy is viral or bacterial infection, seizure disorder, concussion, injury, shock, and hypoxemia. In adults, the risk factors are infectious disease like meningitis, HIV, AIDS, hepatitis B or C, sepsis, liver damage, which again is just alcohol abuse or hepatitis, hypoxemia or brain anoxia, which is just lack of oxygen to the brain, brain injuries such as bleeding or swelling on the brain, kidney failure, brain tumors or metabolic imbalances like acidosis. Other risk factors that are less common but could potentially cause it is alcohol abuse, drug abuse, overdose toxicities, poor nutrition, and lifestyle choices.
My name is Colby Rigdon, and I'm going to go over some other things related to encephalopathy, including pathophysiology, some common signs and symptoms, diagnosis and treatment, as well as prognosis. And as far as this presentation for encephalopathy, we're going to be dealing mostly with cases that occur in adults. And again, just to reiterate, encephalopathy is any alteration or in functioning of the brain or brain structure. It's a syndrome related to a disease or illness, and we'll get into some of that, such as severe increased blood pressure, any infection or attack on the meninges of the brain, malfunction of the mitochondria, seizure activity, hypoxemia, brain or tissue death in the brain, toxic poisoning substances, any autoimmune attack on the neurological system, and metabolic imbalances as well. Brain structure changes, that includes traumatic brain injury or injury involving the head and brain, any edema or swelling to the brain tissue, and that can be caused by seizures, stroke, any type of injury, blunt force trauma, toxins to the brain, as well as hemorrhagic stroke or a brain bleed, increased intracranial pressure, and tumors. And here we have a couple of examples of structural causes in the brain that can cause encephalopathy. A couple of really good pictures there. So what you want to look for, some common signs and symptoms, and again, this is in an adult patient. You're likely to see an altered mental status, loss of cognitive function. You may see some personality changes, as well as inability to concentrate or remember, tremors or seizures, restlessness, lethargy, respiratory difficulties and failure, unresponsiveness. Depending on what type of injury or what the pathophysiology is, you may see fever or hypothermia. You may see functions in blood pressure, paralysis, paresthesia, diabetes insipidus, dysphagia, and abnormal heart rate or rhythm, headache, or nausea and vomiting. As far as diagnostic tests for encephalopathy, you can see written in yellow up there, it's very important to know that no one test is 100% accurate, and we don't have one test for encephalopathy, but we have to run multiple tests, and through examination of those tests, we can make an accurate diagnosis. Some blood tests that we can run include arterial blood gases, which can reveal acidotic or alkalotic states in the body, complete blood count, which could reveal an infectious process, a basic metabolic panel, which would reveal any abnormal sodium or kidney or glucose levels or bicarb levels. Hepatic tests would reveal liver dysfunction, drug screens to show us any toxins in the body, an ammonia level, which could be indicative or could cause a brain malfunction, as well as a cerebral spinal fluid test, which would reveal the cell count and possible toxins of the spinal fluid. Some procedures that we can run through, up at the top and at the bottom, you see CT and MRI. Those are going to both be related to functional changes in the brain, as well as the EEG, which monitors brain activity, seizure activity, or brain functioning, and a lumbar puncture or spinal tap, where we collect the cerebral spinal fluid for lab testing. Many of these tests identify the cause of encephalopathy, but again, there's no one test. We have to use multiple ones to get an accurate diagnosis. As far as prognosis goes, effects can be short-term or long-term. This slide is dealing mostly with the acute or the short-term. Some of the things that we're going to do as far as interventions is give them antipyretics and cooling blankets to keep the temperature down if it's high, antiemetics, intubation and mechanical ventilation, internal feedings or TPN, intracranial pressure drains, antibiotics and antivirals, pain medications, vasopressors to control blood pressure, NG tubes, intracranial pressure monitoring, intravenous fluids, and daily lab and blood monitoring. The patient may also need physical therapy and occupational therapy and speech therapy as well. As far as the long-term and chronic effects, some things that we might have to deal with would be tracheostomy or mechanical ventilation, as well as dialysis, GT tube for continuous internal feedings, Metaport or IV access, possibly getting transferred to a long-term care facility or long-term rehab, and medications for health maintenance. Permanent brain injury or an encephalopathy may result in brain death or irreversible damage, ultimately resulting in overall death. So that's another thing that is certainly a possible outcome in the long run.
My name is Whitney Crawford, and I'm going to be talking about ethical issues related to encephalopathy. I'm going to also speak of how this illness impacts the patient, family, and society as a whole. I'm also going to briefly go over a plan of care for patients with encephalopathy for us nurses. The main thing, as Colby and Ashley have spoken on, and we're primarily speaking to adult encephalopathy, but there is, the main thing is focusing on the primary cause. What caused the encephalopathy? As Colby said, that would help determine a prognosis and treatment for the patients. There are cases where the damage is reversible, just as Colby and Ashley spoke on, bacterial infections that can be corrected with antibiotics, or infectious processes by virals with antivirals. There's also brain injuries that do correct themselves after swelling goes down. So those all play into the outcome of the patient, of course, and how ethically we treat these patients and the ethical issues that will arise. Of course, just some basic ethical issues. If it's a short-term, encephalopathy with the patient, you're going to have things like family decisions. The family decision to put the patient on the ventilator, family decision to get a PEG tube temporarily, or an NG tube to get internal feedings, and rehab if it is something that can be reversed, and they can recover from it. You may have to place that patient in a rehab center for a certain amount of time, and then you also face financial decisions as well. The other thing is long-term. If the patient suffers from permanent or long-term effects from encephalopathy, primarily due to seizures, an acidotic state due to sepsis, or a traumatic brain injury where they had brain stem, affected their brain stem. Those are things that play a little more into the ethical part of things. You have, of course, the family decision there. Do we keep the patient on the ventilator in a vegetative state? Do we put a PEG tube in them? What type of quality of life do they have? And then at the point of brain death, the hospital, once a patient is pronounced brain dead, then the hospital has to step in and discontinue therapy. And those are all ethical issues. Would the family want the patient to continue if they had no quality of life? Long-term care decisions, of course, are tracheostomy, mechanical ventilation, PEG tube placement, vegetative state, coma, quality of life, and long-term care facility placement. Brain death and encephalopathy, of course, is one of the main ethical issues here. When you have severe brain injury and it affects the brain stem primarily, the decision to make this patient a DNR and discontinue treatment, testing for brain stem function is required. And then once the brain death diagnosis, once they're pronounced brain dead, by law, it's required to discontinue mechanical ventilation and treatment at that point. and the family has to make the end-of-life decisions. With a DNR, families have a really hard time sometimes accepting the fact that the patient is still laying there and they still have vital signs, but they are brain dead. So that's hard for families to cope with a lot of times. And sometimes those families will not make the choice, or they want to prolong the ventilation and the treatment. And at that point, ethically and legally, a doctor cannot continue treatment. And each hospital has an ethics committee that can step in and make the decision and overrule that, just because by law you can't keep patients on the ventilator once they are clinically brain dead. And then once a patient passes away, of course, the family has to make end-of-life choices and then organ recovery decisions. Here we have Mississippi Organ Retrieval and MORA, and so some families find it very, very hard to make that decision, and then some family members want it and the other side of the family doesn't. So you get into even some family issues, and it all comes down to just what's best for the patient. How encephalopathy affects the patient, family, and society. First, we want to talk about the patient, and that's going to depend on is it acute or chronic? Is it permanent damage? Is it reversible? The patient for acute encephalopathy may have a difficult time adjusting to the disabilities that they may have, or relearning movement and functions during rehab. They may become frustrated. They may become depressed due to life changes, and they will require daily assistance. It's possible they may require daily assistance in a care facility, which is sometimes hard for the patients to adjust to. They may have financial concerns and child care and other responsibilities that are a concern of theirs if it's affected the patient. Family, effects on the family, they have to look at long-term care options. Support, they have to be there for support for recovery. Financial strain on families. They have to provide transportation and be able, accessibility for the patient if they come home. And then continuous care if they're in a vegetative state, like turning, feeding, and changing, if they decide to take them home. And if not, if it's permanent and brain death, then it's, of course, the end of life, organ donation, and funeral services. Society, these patients in long-term care facilities, you have, they become disabled, you have Medicare and Medicaid taking care of these patients. They're placed in a lot of facilities that are reimbursed. Sometimes those facilities may not get reimbursed for that. And then it always goes back to the initial underlying disease and infection of the encephalopathy. Is it something that could be spread? Is it something that